Thank you very much for the kind invitation. The title of my presentation is GERAADA Score Risk Prediction in Surgery for Acute Aortic Dissection. Is it applicable worldwide? When do we say no? Thank you very much for the kind invitation. The title of my presentation is GERAADA Score Risk Prediction in Surgery for Acute Aortic Dissection. Is it applicable worldwide? When do we say no? As you know, type A acute aortic dissection is increasing in number. These data are obtained from the NACSA database. You can see that from 2009 to 2018, the number of patients affected by type A acute aortic dissection is almost double, from 235 to 510. And the number of dissections is expected to increase even more, especially because of the numerous regional implementation pathway that have been proposed in the recent year, especially in UK after the publication of the dissection toolkit. This is the experience recorded in the Madrid area after the introduction of the local implementation pathway, the OTA code, where you can see that the number of dissections are almost double. However, mortality still remains high. Again, this is the UK data from the NACSA database from 2009 to 2018. From the 23% recorded in 2009, mortality is approaching now 15%. The mortality still remains high, approaching 12%, even in the center where an implementation protocol has been introduced many years ago. This is a typical USA experience where you can see that after the implementation of the protocol with direct transfer to patient to the theater room, mortality still remains high, 12% for the observed mortality and 20.5% for the expected mortality. What about inoperable patient? There are not much publication regarding this. These are the two available publications. One from the Tokyo Acute Superaortic Network, published in 2024, collecting more than 3,000 patients from 2015 to 2019. Among these patients, 7.7% of the patients were judged inoperable, mainly because of advanced age. Another experience is the one published in 2017 by the Cleveland Clinic, collecting data from 2005 to 2015, and among 686 dissections, 10% of the patients were judged inoperable. You can see on the right the reason: prohibitive surgery because of dementia, advanced malignancy, severe malperfusion, severe stroke, and patient considered very high risk post-surgery was mainly due to age, redo, and frailty. Mortality remained high, probably because patients that some decades ago were judged inoperable are now proposed for surgery. This is the typical example of patient with severe preoperative coma that undergo surgery and their mortality is around 50%. Same scenario for the patient affected by preoperative malperfusion. It's well known that higher is the number of malperfused beds, higher is the mortality. As you can see here, mortality is approaching 50% for those patients affected by 3 malperfused beds. Another reason for this high mortality is because a small group of patients which in the past were not able to reach the hospital because of out-of-hospital cardiac arrest due to rupture of the aorta or tamponade are now supported with transportable ECMO, and they are transferred from the peripheral hospital to the theater room and they go under surgery. Obviously, the mortality is high as expected because these represent a very specific high-risk population of patients will reach the hospital in a severe critical preoperative status. If the hospital mortality is high, also the postoperative complications are not negligible. For example, here from the ERTAD study experience, we can see that 20% of the patients experience any degree of postoperative neurological event, 14% CVVH, 14% of patients after surgery go to a heart failure condition, 14% they require exploration for bleeding, 8% require tracheostomy, 4% they develop a bowel ischemia, 3% of the patients require venous arterial ECMO for post-cardiogenic syndrome, and 2% of the patients develop a deep sternal wound infection. Therefore, type A acute aortic dissection is affected by high mortality, high morbidity, prolonged ICU stay, but even when the journey of the patient ended with the hospital, start a new journey based on constant monitoring, multiple investigation, and some of these patients during the follow-up undergo reintervention. You can see on the left side the cost associated with type A acute aortic dissection. Therefore, there is a pressing need to determine how to identify a risk patient. Aim is to improve patient selection, to rationalize resource use, to identify inoperable patient with clarity, and also to consider alternative treatment. Because of this, several scores for type A acute aortic dissection have been proposed, from the ARAD score 1 in 2002 to the Surgeon score in 2023. Definitely, among this long list of scores, the three most employed, at least in Europe, is the GERAADA score, the UK aortic score, and the ARAD score 2. Despite in the States, also the PEN score has been found of utility. As you can see, the main difference between these three scores is based on the outcome. While the GERAADA score is assessing 30-day mortality, the UK aortic score and the ARAD score 2, they are predicting in-hospital mortality. The other variable remain the same, despite the GERAADA score as a more variable to be considered for the final model prediction. The GERAADA score can be found in the website of the German Society for Thoracic and Cardiovascular Surgery. The GERAADA score is based on the German Registry for Acute Aortic Dissection Type A. This registry has a prospective design, is a multi-center study conducted in Germany in 50 heart centers, and they start collecting data from July 2006, is including 90 parameters, and since the publication of the GERAADA score in 2022, 7 publications have assessed the discrimination power through a validation process. You can see here the relevant publication and the comparison of the discrimination power of the GERAADA score towards the Euroscore 2, the UK aortic score, and the ARA2 score. As you can see, the GERAADA score shows a moderate discriminatory power, but also an underestimation in low-risk patient and an overestimation of 30-day mortality in a risk patient. This is due, as all the model, because the external validation of the GERAADA score has been assessed only by a minority of studies. And this is very common with all the validation process for the other risk score. One of the confounding factors affecting the GERAADA score as well as the other risk score is the interaction between age and gender, which is very difficult to predict, especially for those patients above 80 years old, especially in the female group due to the limited number of females that normally undergo repair for type A acute aortic dissection. Another confounding factor is the race. We know that on non-white race they have a different mortality rate when affected by type A acute aortic dissection. None of these scores include the race as a variable. More importantly, there is clear an interinstitutional confounding effect that can be seen here in the ERTAT study. You can see that some centers perform very well, while others do not. One possible explanation resides in the patient selection, but another explanation resides also in the experience and the skill of aortic center. Another confounding factor is definitely the hospital volume. It's well known that high volume center perform better. High volume center performing repair of type A acute aortic dissection reveal constantly reduce mortality and morbidity. Therefore, it is not unusual an overestimation of observed versus estimated mortality ratio in high volume center. Another confounding factor is represented by the capability of some centers to support even the sicker patient following repair for type A acute aortic dissection. Here you can see an example of patients supported by ECMO following post-cardiogenic syndrome, following repair for type A acute aortic dissection. If it's true that the mortality is very high, 17.2%, it's also true that a minority of these patients, around 25%, can survive. Therefore, there is the ability of some centers to provide exceptional support with the ECMO aid, which clearly cannot be included in any kind of risk score. In addition, another confounding factor is the definition of the malperfusion criteria, because definitively, as shown by Gemelli and colleague, when the clinical GERAADA score is based on direct assessment of the malperfusion of the patient, the discrimination power of the GERAADA score is higher. Another important element is the lack in the GERAADA score of the inclusion of the preoperative lactate level, which mimic quite precisely the extent of the malperfusion syndrome. When the lactate is above 3.2, you can see clearly here that the mortality is above 30%. There are patients that, irrespective of the GERAADA score, should be considered inoperable. The answer is probably yes. This is the experience from the Lefteriades group, who show that after 60 months, the mortality between patients treated surgically and medically is almost the same, suggesting that probably in some group of octogenarians with a severe profile of comorbidity, surgery should be not considered as a viable option. Therefore, the GERAADA risk score has to be weighed against the expected outcomes. Interestingly, for inoperable patients, we should potentially consider alternative strategy. I showed you before the experience of the Cleveland Clinic with inoperable patient. When they revised the preoperative CT scan, they discovered that 79% of the patients deemed inoperable could have been treated with endovascular stent. And in the era of artificial intelligence, probably in the future we will have more precise risk score than the GERAADA score. In conclusion, the GERAADA score was not designed to deny aggressive treatment in patients deemed not fit for surgery, but the GERAADA score has been designed to help clinicians while making recommendations about complexity of surgical approaches, counsel patients and their family in helping them to understand their predicted risk and to have a realistic expectation in terms of outcome, but also is offered the possibility to evaluate the group of patients who probably benefit from other alternative approach like the endovascular approach. Thank you very much for the attention.